Hello and welcome to the Trust Driven Podcast. Today is another episode of Trivia Day. I'm your host, Dr. Melanie Short. I'd like to introduce our guests today who are playing trivia. First of all, we have Dr. Catie Wonders. She's a chiropractor in Gettysburg, Pennsylvania. Maria Naidig. She's a registered nurse and a patient advocate in Columbus, Georgia. Dr. Jeff Langmaid, who is the evidence-based chiropractor in Tampa, Florida. And Dr. Nolan Clausen, who's a chiropractor in Omaha, Nebraska. Are there any questions from our guests today?
Let's do this.
Let's do it, yeah.
Go right into question one. The title of this article is called Closing the Gap, the Patient-Physician Disconnect. It's by George Mialois, Jr. It was published in the HealthMark Quarterly Journal in 2009. So your question is easy. Let's start it off easy this week. We have a true or false. According to the article, 90% of patients are seeking support for their emotional feelings and then their physical symptoms. So we are trying to decide, is there an emotional part of it or physical first? Essentially, what did they find?
All right, so we have 1 minute to discuss.
Yes, question your sanity.
Is this what the physician thinks that
Right.
they should be
Like an
seeking out?
initial visit.
After.
Did they find that, so it was 150 focus groups talking to patients about what they want addressed during their initial visit. In this case, is it true or false that there were 90% of the patients wanted support for their emotional feelings other than their physical symptoms first?
Are they
Yes.
figuring this out after we are doing a case history and then we get done with the case history and they understand that,
Well, we're going to find out.
yeah, that's probably more emotional?
I think it'll be interesting to see what the answer is. I'm not sure if people go seeking it. My
Right.
personal opinion is that 99.9% of patients need that support. And quite frankly, that support is far more impactful than any physical thing that we do. Regardless of your technique, regardless of your profession, placebo showcases that because it works, and it works better than most things. Like 50% placebo outperforms surgical intervention in the spine, which is absolutely insane. So in my opinion, but it's that's bad news for patients. I think it's good news for us as providers if we spend time with our patients, because the amount of time, and I'm not necessarily saying longer time, with the amount of focused time, whether that's 2 minutes, 5 minutes, or 30 minutes, that focused time and the ability for somebody to understand, connect, and drive hope is, in my opinion, by far the most important thing that anybody can provide. And then it happens to be that we apply, whoever we are, some form of physical craft to that, with that patient. But ultimately, I think that the mental component is the primary component in most things. It might not be the cause.
Yeah.
It certainly can be
Definitely.
the care.
I guess this one is looking at whether that's what the patients were actually seeking too. So I think we found that overall the outcomes point that way. It'll be interesting to see if that's what the patients are
Yep.
going into it looking for also.
I wouldn't be surprised if the patients are oblivious and they're like, "Nah, I don't need a
Yeah.
Right, yeah.
That's the other guy." But which I think that's the interesting aspect of the true and the false. Are patients seeking it? I don't know. Do they need it? Literally 99.99. There's probably one exception in the history of mankind, and I have yet to see it.
I was just going to say it sometimes takes 5 or 6 visits before somebody would even admit that they would need some sort of emotional.
I agree with that because they want to trust you first, right? All right, let's see what you guys thought. So, Catie, let's see what we got. I see a big T. Maria got true as well. Jeff, that's a T. Oh, that's a beautiful drawing. T. And then Nolan had an F for false. There we go. Okay, well, let's check out and see what your answer was. It was true, which I thought was a great point to cover us, that it was 90%. That's such a high value that patients really want to be validated even more than their physical symptoms. They want that short-term satisfaction of talking to somebody that cares and getting that kind of emotional support out of it prior to even having any sort of treatment.
I'm surprised that they admitted that.
Remove, yeah. Well, it was a focus group too, so they had to remove them from the setting, right? So it's not talking to the provider saying that oh, I needed the emotional support, but what they were actually seeking was to be validated, essentially, over even more so than their, their physical ailment.
In the practice that I'm a part of, I'm not in it daily, but we actually coach and train on this with our doctor all the time. We call it the life effect or life impact. Somebody will live with pain forever. It's only when that pain precludes them from doing something that they want to do. Now, if somebody that works out 3 times a week, 2 days of pain might be enough because they're like, I missed a workout. Most people, how long you been dealing with this? 10 years, 20 years, 30 years, 5 years. And we always tie every single aspect. We find life effect out as the I could actually care less about the location first. I actually care about the life effect as the number one thing. And then everything we do, from an examination, from an OPPQ or ST, from a care and treatment plan recommendation to get to yes, I don't mind talking kind of salesy terms, all of those things always directly tie back to the life effect in terms of our conversation, so that the patient can understand that there's a clear path to what they want. And that's what we always say, our reputation is built upon 2 things, your goals and our findings. And that's also how our care plans are created. The findings we get on physical examination and your goals matter, because your goals might be dramatically different than what we have as goals as a provider, right? As a provider, we see all of these things. We're like, oh my gosh, this, that, and the other thing. The person's like, dude, I just want to do this one thing. And that's often when patients ghost practices, or a lot of doctors, I could go on and on this. I won't, but that's a majority of the problem, in my opinion, specifically in the chiropractic realm. But actually, we're better than most other healthcare. Most other healthcare is so atrocious. Just not being horrifically bad at it makes you better than everybody else. Chiropractors, I think, tend to still be worse at it than they should be, because we focus so much as chiropractors on the clinical aspects of care and not as much on the conversational aspects of human beings, because often doctors feel like that's sales and they get turned off when it's actually part of being an own human being. But
That part of
that's my take.
Okay, everybody, we're going to cruise on to question number 2. The title of this article is Physician-Patient Communication, the Relationship with Malpractice Claims Among Primary Care Physicians and Surgeons. It's by W. Levinson, and it was published in the Journal of the American Medical Association, and we're taking it way back to 1997. And your question on this one is, specifically for primary physicians, the overall length of a visit was significantly higher for physicians with A, no malpractice claims, B, some malpractice claims, or C, many malpractice claims. So essentially we're looking at like the length of time you spend with your patient. Is it better to spend more time? Is it better to spend less time? So we're looking to see if a primary physician, so primary care, spends more time with their patient. Are they going to have no malpractice claims, some malpractice claims, or many malpractice claims? And I know this isn't speaking to the quality of said time, but this study was specifically just on like length of time spent in relation to malpractice or malpractice claims. Maria's got her thinking cap on over there. All right. I'm going to go ahead and let's get your answers. Nolan, you go first. I got an A. Okay. And Maria, A. Okay. Catie also had A, and Jeff chose B. Okay. Let's see. It was A. So in this case, they found that patients that spent more time, specifically the primary physicians that spent more time with their patients, had no malpractice claims.
That surprises me. I can't believe that they wouldn't be sandbagging themselves.
Well, that was the conversation I was having with myself too. It was like, some people just don't know when to wrap it up. So
Right.
you might end up in that, like, I've talked myself into a situation where sometimes less is more.
I think maybe it's just that patients are surprised that they get enough time with them, that they don't feel as obligated to report a malpractice claim.
That's probably true. And when they look at overall, like, the amount of information that a patient can recall from, especially from an initial visit, but the amount of overall information a couple of days later is much lower than you would think. So maybe just the amount of time is the standout information that they've got.
The interesting thing would be the amount of
Yes.
time, because I know that most of the visits are 60 seconds. So
Right.
I feel like, again, Josh, these are coincidental things, but Josh and I were talking yesterday about somebody that he was speaking to, a chiropractor, about like a hour-long visit or something. That made such little sense to me. It was difficult for me to humanly comprehend what that would be, unless you were Greg Rose at TPI taking care of like a professional golfer who's paying you 10 grand an hour.
Right.
It was very difficult for me to understand conceptually how that could be a good clinical or business idea. So I'm interested in this. Did 60 seconds become 3 minutes?
Yeah.
In which case I'm like, oh, that makes sense. Like,
Right.
it doesn't, it was 30 minutes or something like that. I'm like, it's impossible for them not to sandbag themselves, because you would just go off into a million different things. Patients are going to have questions. You're going to be taken off task. There's just too many opportunities for things to go askew. Because again, I have pretty strong opinions about this, but in my opinion, most of a good visit is templated. That doesn't mean it's like an automaton, but you need to know your destination, right? So if you're spending 30 and 60 minutes, sometimes you can do that. I'd say script, because it's not scripted like you're a television actor, but I mean in terms of ADIT formula. Okay, I'm going to acknowledge, introduce, duration, expectations, and then transition. So I'm going to set myself up for success by having a patient understand from the get-go what we're going to do, how long it's going to take, and what my goals are by the end of that visit. And that's, I think, a critical part of patient experience. So long story short is I would be interested to know whether this went from 60 seconds to 3 minutes, at which point I'd be like, oh, this makes total sense. If it went to like 20 minutes, she's shocked that this would be the answer, but I never know.
For the like no claims group, it was 18.3 minutes was like the mean of the clinicians that did not
All right.
have any claims. Their mean time was 18 minutes or 18.3 minets. So close to 20 minutes.
That is a long time.
Which does feel
For-
like an eternity
The-
compared to those patient-doctor interactions.
Specifically for like an initial consultation.
I got patients that are just only, and 20 minutes would seem like a lifetime to be with them.
Yeah.
I think it would seem like a lifetime for you and for them.
Yeah,
We have things to do. Like, I squeezed the number of appointments that people will squeeze in. Like, I was driving by and hoping that on my way between, getting off work and picking up the kids,
And
that
I
would feel better by the end of today.
Study was specifically for primary physicians. Because even if you think about like physical therapists, like they'll spend an hour with their patient. So like that, like it's relative on type of service you're receiving. Okay, hey, let's move on to question number 3. Okay, so the title of this article was Surgeon's Tone of Voice, A Clue to Malpractice History. It's by Nalini Abadi, and it was published in the Surgery Journal in 2006. So your question here was general and orthopedic surgeons who were judged to be more dominant via voice recording were more likely to A, gain patient trust than those that sounded less dominant, or B, do their job better than those that sounded less dominant, or C, have been sued more. I think it was supposed to be sued more than those that sounded less dominant. So we had a theme today was kind of about like malpractice. Like how could we make our communication better to not have, malpractice issues? And we're opening it up to kind of different professions too. So we talked primary care. Now this one's going to be more on surgical. This case is interesting. So they essentially voice recorded surgeons doing routine visits with their patients. Like it wasn't just a specific like initial or like post-surgical appointment. And they took 10 seconds of like the first minute and 10 seconds of the last minute. And then they played those for a group of people that were not patients of those doctors. And the patients that were listening to the voice recordings kind of rate them as in like, is this more dominant? Is this less dominant? Like tone of voice. So the patients that were you're kind of doing the questionnaire after were not patients of the actual surgeon. So they did not meet them. They don't know their life story. They only know their voice.
Interesting.
That is an
It's
interesting.
just otherwise, it's kind of like, oh, well, I know the guy. Like, I trust him.
So the people doing the judging were not patients. They were judging the dominance of the surgeon's voice and then deciding whether, and then matching that with whether they were more likely to
Yeah, would you trust
do
that
those,
person?
which of those
Do you
three
think they do a
names.
great job?
Okay.
Would you sue them? He's got a couple more seconds here.
I'd like to know what their judgment of dominant means on that.
You know what? They didn't do a great description about like how they came to that. So it is a little subjective because and it's supposed to be about the tone of voice, not specifically what they were talking about. But so loud, like what I was thinking about when reading this article was about like dominant would be louder or maybe speaking over a patient or, kind of being more forceful. But let's get your guys' answers. Let's start with Jeff this time. You see, we got an A. Okay. Catie, C. Okay. Maria also went with C. And Nolan, A. All right. Well, there we go. We're split 50-50.
Confident, right?
So it was C. So it's have been sued more essentially than than like a voice that was less dominant. So the guys get points and you guys, it's all up now. Everybody's got 2. Yeah, this is just interesting about how to speak with your patients too. Like,
So the more dominant
yes,
voice was more likely to have been sued.
Mhm.
Is the takeaway.
All right.
Interesting.
We actually talk about this all the time in our clinic. We're 2 male dominant clinic now, and so when we have females in, we're both over 6 foot tall, so we try to shrink ourselves down when we're interviewing and trying to be less dominant because we are both males that are fairly dominant.
How do you do that?
So-
Like, do you stand? Do you sit? How would you?
I sit on a stool and I kind of scrunch myself. I bring my shoulders together, things like that. I'll lower my stool, so I'll be lower than them. And they'll be a little bit higher on the bench, things like that.
You said you talk about that a lot in your practice.
Mhm.
What was coming up that led to that discussion?
Nothing in particular. We are a 2 male doctor practice now, but we did have a female, and she handled a lot of postpartum rehab stuff. So we are still getting postpartum females in our office. And so we have to be mindful of that because we had this reputation of having a female here that was awesome. And so we do tell them ahead of time that she is no longer in the practice, but we still got to try to convey that we're not just some big ogres treating them, So that's why we talk about it. And we talk about it with even our receptionists and our trainer, just the different physical types that walk in the door and male versus female and all that stuff.
That's interesting because I think I have experienced the direct opposite perspective. And it sounds like my physical stature is directly opposite of yours as well. So we've spent a lot of time and energy of we have to convey confidence and make, if we get a big honking guy come in, one of the early in my practice stories was having a very large man ask what a little girl like me was going to do to help him. And I was like, there's so much to unpack right there, but don't worry, we'll get to it.
Definitely, I had some of those instances too, and I have probably 3 or 4 inches on you. So, you get any kind of feedback from patients about doctors' tone of voice, or do they speak to you at all about I had a great experience or a terrible experience?
I have one patient in particular who had knee surgery, and the reason that I chose C, because I read this question a lot before answering what I did, and I listened to like what you were saying, and it just came up as like, yeah. So my patient basically had knee surgery with this person who was very dominant, very cocky. And I'm just thinking like, if these, if these people are reading this and they're not even like the patients that were there, like how would they kind of portray it? How would anyone portray someone who is coming at them very dominantly, very much like, I know better than you do? Like, I don't think that, like, it's definitely not going to gain the patient's trust. The patient's going to be like, next I'm going to go check out who my next doctor is going to be. Do they do their job better? More than likely not. They probably do it worse, and they're making up for it. In my opinion, like in my own like nursing opinion, some, dominant doctors are really great at their job and they know what they're talking about. And if you don't know what you're talking about to them, they will like run down the hallway from you as fast as they can. As far as like orthopedics or surgeons, I don't think anyone who is having any kind of surgery is going to want someone who thinks that they know better than their patient, or they think that they're doing a better job because their voice is more dominant. It could be like the confidence, but I can also like that separation of relationship. Like, you're not here to help me, you're just here to make money. And that's what that's not going to make them any more money than they already have or have had. So there are people who like that. There are people who like very direct, very dominant doctors, and that's great. But like the majority of the people, especially, I mean, the age group that I deal with the most is like between the 60s and 80s. They do not like dominant, like the super dominance. They want to feel like their doctor knows that they understand what they're saying and don't tell them that they're wrong in what they're reading or that they're not understanding it. A lot of them are going for like NDs or DOs versus NPs and PAs. It's just what I've seen with
Thanks for
like my advocacy.
And I did want to rewind real quick because I had my answers backwards, and it was actually the ladies that pulled ahead with this one. Boy, back to my score sheet. So Catie and Maria are both at 3, and Jeff and Nolan, you guys have 1. So let's see how we pan out. We still got 2 more to go. So let's see. We can all tie up here.
Imagine a practice where patient engagement is seamless and unified. With trust-driven care, connect with patients across text, email, social media, and Google Business Chat, all on autopilot. Empower your team to step in effortlessly and engage in real time from anywhere. Say goodbye to multiple software and hello to a simplified practice and life. Trust-driven care is the all-in-one solution to save time, boost revenue, and build patient loyalty. Book your demo today and watch your schedule start to fill up. Now, back to the show.
All right. So moving on to question 4. Your article title here is, If Your Feelings Were Hurt, I'm Sorry. How third-year medical students observe, learn from, and engage in apologies. This one was by Ian Fisher. It was published in the Journal of General Internal Medicine in 2021. And your question here is, when studying the 4 elements of an apology, which I will give you after you answer, it was found that what 2 elements were the most important in a sincere apology? So is it A, acknowledgement and remorse, B, explanation and reparation, or C, acknowledgement and reparation? So first of all, you guys need to know the 4 elements of an apology. And then which 2 are found to be most important for a sincere apology. So I'll give you guys a little bit of info on this one too. So they took, it was about 73, almost 7,400 narratives. And within those, so this is within school, so within medical school. Then of those, 238 included apologies. And then so they kind of looked through the apologies and found out which was, the most important parts to make a patient happy and to like actually sincerely kind of like fix whatever the problem was. All right, you guys got about 15 seconds. Also, like, interesting about this article, since it was students, was they were basically showing that professors need to teach this because otherwise, they go off and they do their residencies, or they do, or like in different, it could really go with any sort of like certification or licensure. When you're following somebody or interning or doing that residency, you're just going to kind of mimic what your like overseer is doing. And if they tell you like, this is what you have to say, or don't say anything at all, or this and that, you're just going to kind of listen, because as a student, if you didn't know like where else to go, like you're just going to kind of listen to whoever your superior is. Where if we had learned these things in school, it would probably make it easier. I don't remember talking about apologies in chiropractic school, but I don't know. Catie was there with me.
The only thing that I remember from like specific to apologies was regarding malpractice. And my takeaway anyway was don't, because an apology is equal to admitting that you did something wrong, and admitting you did something wrong is a liability. So do everything to be nice, except say, yeah, oh, I'm sorry.
If you guys answers, then we can kind of discuss it a little bit. Okay, Catie, you go first.
I went with C.
There we go. C as well. Nolan? C. All right. That was popular. And how about Maria?
C.
C as well. All right. Well, all right.
All right.
So, but yeah, so the 4 elements of an apology: acknowledgement, explanation, regret or remorse, and then reparation. And it wasn't from this article, but Dr. Satterley and I have talked kind of like in extense about apologies. And there is so much newer research that is great about showing how if you give an apology, you are less likely to have a malpractice claim. Where I feel as though in school, or even from our like insurance carriers, they typically tell you the opposite.
I was just patients do not care about the explanations. They just want to know that they were right, and they want to know how they're going to get repaid
Yeah, well, I think the acknowledgement's a big part too, because if you're just, I don't even know, like even just regret or reparation, or even just like explanation, like even though you're still giving me what I want in the end, if you don't acknowledge it, or like they're like, well, they still didn't say they were sorry. They still, they just gave me, $20 off my next visit or whatever.
I thought the title of the article is a little telling too. If your feelings were hurt, I don't know anybody who's got really solid friendships or relationships that's taken the like, I'm sorry you feel that way route, and really having a successful time with good connections.
I just think about Google reviews, how you respond to them. I mean, it's always, I'm sorry, and we are going to do better next time, or we are going to train our staff so that this doesn't happen again.
They typically skip over the fact that, nobody called me back or whatever. You say, I apologize that nobody gave you a call back. We'll redo training.
Right.
We'll talk about it, whatever.
Yeah, we've had patients take down their 1-star reviews because we just did the acknowledgement and reparation.
A lot of times it's a misunderstanding. It's not even that like you did something wrong. It was just like a misunderstanding, and like, being like, okay, maybe this wasn't clear on our website, or we didn't say it, we'll fix it.
Or just managing expectations in general. Like, I think that when people are looking for answers, it kind of goes back to, the earlier questions. Like when people are looking for answers, then, well, now we know 90% of them are seeking validation. Then, if you screw that up, then validating that that's what happened.
Yeah.
Seems like it would
Right,
fall in line with that.
On to our last question of the day. The title of this article is Effects of Communication and Resolution Programs on Hospitals' Malpractice Claims and Costs. It is by Alan Cachalia, and it was published in the Health Affairs Journal in 2018. Your question here is, communication and resolution programs have been found to A, decrease malpractice claims, B, increase in defense costs, or C, increase in malpractice claims. So these programs were implemented in 4 Massachusetts hospitals, and kind of just showing before and after trends of like implementing a program where there's communication and resolution. And the trends, like things that they looked at were claims volume, the cost, and the time it took to kind of resolve. Maria, do you deal with any programs like this in the hospital or have before? Or like you've probably had some hospital time, right? So like, is there any like, do you have to tell HR about a certain thing, or do you have to tell, if something happens, is there anything for, staff in order to kind of like negate or kind of get ahead of something negative happening?
So there's something happen, but you catch it. It's like a near miss. I believe those are reportable. Incident reports where something actually happens are also reportable. Like falls with injuries is an incident report. I actually had a patient who had a fall with injury. I was working overnight. It was like 5 o'clock in the morning. She was making her bed. She was, not all there. But she was making her bed. They had the TV on and we were talking about the weather. She was completely steady on her feet. She just took like one step and she fell back and hit her head. I was mortifying. I had to call the family and let them know, hey, like this is what happened. For me to find out that she had been falling multiple times at home, that this was probably her way of showing that she needed to go into some kind of nursing, unit type based like living. Yeah. I mean, my manager had me in a conference room with a woman who they were literally like just picking apart what had happened. And it was brutal. It was brutal because there was maybe like a couple days prior, there was another patient that had a fall with injury, and she didn't have to go through the same thing I did. I got scrutinized for mine. So it was like a punch to the gut because I didn't think that she was gonna take a misstep or anything like that. You can't I'm running across the bed. Like I'm running around the bed to get to her before she falls and I can't catch her. There's literally nothing that I can do in that moment. But yeah, I mean, they do. And then if there's an injury that leads to a death, it's called a sentinel event. That's a pretty big deal. Yeah. And also reportable. So really like the incident reports and like the sentinel events.
Okay, like staff would fill
Mainly what I dealt with
in the hospital, like administration would reach out to family and
it was mainly the incident reports were mainly, they were filled out by the staff.
Okay.
And it went to our manager. And then he would talk to us about the incident. The sentinel events though, that would go probably to our manager and then they would, take it up higher because there was either, I was on a monitored unit, I was on telemetry. So we took care of patients with chest pain, heart rhythm issues, heart catheterizations. I mean, so we also had patients that were being monitored on different units and we had our monitor techs. But a lot of times the nurses, they had to carry the walkies to be able to talk to the monitor techs and wouldn't always answer the techs. And so if there was a patient's monitor that needed new batteries or whatever have you, they would try to walkie. I mean, there would be patients going through all different kinds of heart rhythms and sometimes the nurses would respond and sometimes they wouldn't, but if something happened, it would turn into
important. All right, let's get your guys' answers. Nolan, you go first. Hey, okay, decrease malpractice. Good. Hey, Maria. Hey, Catie. Hey, and Jeff. Hey, look at that.
Like Jeff and I.
So having a program, instilled in the hospital. So essentially these programs communicated with the patient or patient's family and came up with a resolution, and it led to having lower malpractice claims. So essentially acknowledging that something happened and, hey, we're reaching out to let you know, how can we resolve it prior to, needing to go to like the malpractice level.
To put you on the spot, Melanie, I don't know if they actually discussed the defense cost in
there was not
article or not,
I
or if that
knew
was just a filler.
that, it decreased the defense costs. They didn't. There's no monetary like number. Like it didn't tell me like how much the hospitals were, like how much they were paying for their defense. But like there was no number. But it does actually decrease the defense costs because if you don't need malpractice claims,
Interesting.
if you're not having to hire attorneys to do certain
Right.
things, then your cost is going to decrease. Awesome. So we have a tie, Catie and Maria. Maria, poor thing, gets stuck on these questions the last couple weeks.
Here we go.
Oh, like,
Again.
so ladies, your question for the tiebreaker is how many Crayola crayon colors are currently available?
Oh,
It has to be non-medically, because if I gave you like a question about a bone or something, you guys would both get it right. So it has to be obscure. Many colors, because apparently I have retired many colors.
I am not
Yeah.
up on brand knowledge at all. So,
But Catie, I have you down first. Alphabetically, your name comes first. First name, at least. So I'm going to have you throw out a number for me.
I'm going to say
And Maria, how about you?
256.
I am thinking way lower. I'm thinking like 85.
This is like Price is Right. Like, he's the closest.
Okay, and the winner was Maria, so it was 120. It was 100 and...
120. Oh, wow. We're slacking on the
It's
colors.
been close to like say colors, but they retire them. So I mean, a little bit of Crayola crayon knowledge to your.
I want to be on that meeting where they're like, these are the ones on the chopping block. What are the irrelevant colors?
Yes, Maria Naidig. And Maria, do you know what organization you'd like your donation to go to this week?
Yes.
You've been waiting for this moment.
Months. I am so excited. The Congenital Heart Defect Foundation. For those that don't know, my son was born with a non-life-threatening congenital heart
He's been
defect.
doing great.
Yet cleared again 2023 until we leave here. So 2 to 3. But the cardiologist here said that he would clear him until we leave. And then before we leave, he'll clear him again so that we don't have to find another cardiologist wherever we go. But yep, he had his repair when he was 4 weeks and 6 days old. And he is thriving, and I love it every day.
Well, I would like to thank our guests for joining us this week and having some great conversation and getting most of the questions right. I'd also like to thank our listeners for joining in on another learning journey with us. I'd like you to come back so we can discuss more stimulating medical communication research.
Thanks for tuning in to this episode of Trust Driven Trivia, brought to you by Trust Driven Care. Imagine a world where all your patient communication is in one place, seamless, effortless, and on autopilot. That's the power of Trust Driven Care. If you're ready to streamline your practice, check out trustdrivencare.com and see what's possible. Join us next week for more laughs, new guests, and fresh questions that turn medical research into pure fun. Trust Driven Trivia, making healthcare knowledge exciting, one question at a time.